Okay, so hi guys and welcome back to the podcast. We're doing something slightly different / new today. So we're sort of introducing a new subsection of the podcast called stat cases. And what we're going to be doing throughout these cases and hopefully throughout the year is engaging with many other people that are not me and Matt.
Not that you're bored of hearing our voices, but
I'm bored of hearing my voice.
bored of hearing our own voices.
So we're hopefully going to get some good presentations from you guys out in clinical practice. These are going to be shorter, bite-sized episodes that will look at a single topic and hopefully get some really interesting cases. So we're lucky to have one of our, the first ever student to be on the podcast, Sara.
Excited.
You're pretty psyched to be here.
I'm so excited.
Yeah. So actually you made a rub for your own back with this because you emailed us to say I had an interesting case and then we said, well, we have a podcast.
It's a match made in heaven, really.
Yeah, and completely involuntary. What we're going to do is just hand it over to you, Sara, and then read out your case to us. What's going on?
So I saw a 70-year-old gentleman. He came in to GP, just got an appointment on the day, just walked in to see if he could, what the chances were if he could get an appointment. Wanted to talk about some side effects of his amlodipine that he'd just been started on. So I went and saw him, and he had a number of very vague side effects, all of which weirdly had stopped by the time he had seen me. So it was a bit of a why have you come? What are you here for? He mentioned that he had some weird ache in his chest, so he said it was just a bit of an ache constantly there, sometimes got a bit worse, but very non-specific, sounded quite musculoskeletal if I'm honest, whilst he was moving, things like that, lifting things and stuff, and never really got better, was just kind of always there. In terms of past medical history, he was someone who was quite needle phobic, quite scared of going to the doctors, hospitals, drugs, so the only thing that was on his records was hypertension, and because he was needle phobic, he was very specific and quite medical phobic specific about what therapy he'd be started on. So amlodipine was something that he'd been started on after quite some resistance, but apart from that he was on nothing else.
Because is that the fear of him having to have sort of renal function checks?
Renal function tests, and he didn't want regular monitoring, anything that was going to be invasive. He didn't like coming to the doctors, it taking him so much effort to come into the doctor, so he kind of wanted to be put on a treatment that he could just be put on and then left. So that's why he was on the amlodipine. But he hadn't really been on it that long at all. But apart from that, nothing else medical at all, apart from some psychiatric stuff when he was younger about his medical phobia. Spoke to him a little bit, examined him, nothing really of note. I think he was hemodynamically stable, his blood pressure was fine, pulse was fine, regular, about 90. But thought we should do an ECG just because he mentioned this weird sort of ache. Yeah. But it was more just we should do one as opposed to thinking it was actually going to show anything. Got him an ECG and it showed
Existently.
Imagine.
I'd like to think that Sara could pick that up before an ECG.
A testament to our medical education that Sara is aware of what is deceased and what is not deceased.
Yeah, I mean that's all you guys in your SimMan sessions.
Thank you.
I got him an ECG and he had left bundle branch block, so weren't expecting that at all. Even whilst we were talking, he was like, I still got this big ache, but it's not really causing me any issues, not radiating anywhere, just kind of dull and everywhere. So, obviously, because he's someone who's never been to the doctor, never had an ECG before, so we couldn't tell if it was a historic left bundle branch or not. Had to obviously gave him 300 milligrams of aspirin whilst he was in the surgery, and had to call an ambulance because potentially could be having an MI. But even then, didn't really think he was. So, the GP I was with was very, you take this case, so I handed over to the paramedics, but was very I'm really sorry, I really don't think this is a STEMI, don't need to waste your time. Went to the hospital, checked on the system. The next day he had a troponin of 7,000. His wife rang us and he was being considered for a triple bypass, so it was just, completely unexpected, and maybe wouldn't have even done the ECG if I thought the chest pain was a bit weird. I wouldn't even call it chest pain, a chest ache.
Well, that's a really good learning point, though, isn't it? Because that's someone you have a low index of suspicion for actually being acutely unwell. You sort of said it yourself. It does sound very muscular. If his pain is worse when he's picking stuff up and he's moving around, that sounds like it's very much muscular chest pain. How old was he roughly?
70-ish, in the 70s, but very fit and healthy. Didn't look 70 at all.
And actually, the ECG isn't I think this is ACS, or I think this is an acute coronary syndrome. We need to see what type of acute coronary syndrome it is. We'll just do a reassuring normal ECG, and then we can send him on his way with some paracetamol and say it'll get better.
Yeah, that was definitely it.
Yeah.
So I guess it's like at this point it would be interesting to think about what it could be, what it could have been. Obviously, we know what's happened.
Yeah.
But what could have been the alternatives there with his presentation? So he's coming with some side effects from his amlodipine.
Yeah.
So a lot of patients can present with any number array of side effects, can't they, including chest pain. I'm not sure of the exact side effects for amlodipine and whether that includes chest pain, but it certainly could be a side effect of the medication.
It's not something we'd expect from amlodipine. Or lots of most medications. Chest pain would be an odd side.
Or I suppose the vague symptoms that he was kind of telling you. It's a bit less likely. Yeah.
Like reflux, I think, is probably quite a common side effect for lots of medications. It's something you could easily sort of fob someone off with inverted commas. They've got some epigastric pain that doesn't sound particularly exciting after starting a new medication. It's probably reflux.
So side effects based stuff. I mean, what else could this be, Matt? In terms of prior to us actually pre-alerting this, we've got this guy with chest pain, got a bit of a left bundle.
I mean, it doesn't sound like a dissection or anything.
No.
When we sort of go into the chest pain territory, we tend to, well, certainly I tend to start quite high up, thinking I think it's just the nature of the place I work. Is it an acute coronary syndrome? Is it a dissection? It doesn't sound like either of those. Really,
it wasn't convincing of anything serious. I thought it was anxiety.
And that's the classic, isn't it? That's what's quite interesting, is that Matt might be thinking about thoracic-based stuff, and then alternatively from general practice, you think, is it anxiety? Is that a completely different set, isn't it? But then I suppose something else to think about is what are the other things? So pulmonary embolism. Does it sound like a pulmonary emboli type situation? So you're then starting to think about your sort of Wells type questions. In addition, thinking about things like respiratory infections and whether actually there's been a musculoskeletal chest wall type injury from that. Thinking about exercise-induced sort of muscular injury, whether these a lot of these individuals come out and they've been in the garden doing a heavy workload or something, and then have gone inside and noticed that they've got a gradual onset of some reproducible tendinous chest wall based stuff. Before we then go down into other things, and as you say, Matt, sort of even just sort of reflux, non-medication related, but because you expect that really from polypharmacy, don't you? Actually, but in that individual, I think it would be relatively reasonable to consider reflux as a diagnosis. Yeah. And so, what was pertinent about that ECG then for you, Sara, that made you that because you said that wasn't expected. So what were you expecting, and why was that kind of pertinent to you, I suppose?
I think I was expecting sinus rhythm. Yeah. Or maybe slight tachycardia because he was anxious. That was it. So then when it was left bundle branch, firstly I didn't expect to see any abnormality. Then it was left bundle branch, and I thought, he's probably had this historically. And I also wasn't convinced he was having. It was chest pain and left bundle branch when I was seeing him. I thought he was having a bit of an ache, and this is coincidental that we found the left bundle branch block. Yeah, that's why I just was shocked. And then even when he went in the ambulance, still wasn't convinced that it was going to be a cardiac thing. And
I suppose because the concern here is this a new onset left bundle from an ischemic sort of left ventricle, isn't it? Actually from an occlusion, and I think it's also one of those protocolized findings where chest pain plus left bundle probably gets brought in quite a lot for troponins and for sort of further monitoring, because the problem with left bundle branch block is that it's very difficult to see and diagnose any underlying ST elevation, isn't it?
And we have the thing called the Scarbosi criteria, which we'll put a link to in the show notes. Mainly because I can't remember now. But that basically gives the criteria for an ST elevation in somebody who has a left bundle branch block already.
It's essentially looking for massive ST elevation or disconcordant ST depression, isn't it? That looks bizarre. So it would be that left bundle, but really significant.
Odd looking left bundle.
To look different to if he had already historically had a left bundle branch. That would now look different if you had the ST.
Yeah, potentially, yeah.
Okay.
But not all the time. These are the sort of things that come, that starts to get into quite advanced ECG interpretation, doesn't it?
So what if at the time, say he had said, historically, I had these symptoms, I'm not having them right now, I haven't had them for the last few days, I'm not in chest pain, and we've done an ECG for whatever reason. Left bundle branch block in the absence of chest pain, should we still send him to the ambulance because it's new left bundle branch block on the ECG?
I think the significance of somebody having a new left bundle branch block, irrespective of when they had pain, means we presume at some point they've had an event.
Okay.
They might have just, for whatever reason, flipped into a left bundle, which is unusual. But I think the safest thing for us to do is to assume at some point he's had an event. And even if he presents 2 or 3 days after an event, he's still somebody who needs to be seen acutely by a cardiologist. So they actually did, you did all absolutely the right stuff. And I think it's just interesting. Your final sort of comment there was that we sent away the ambulance, and I still wasn't particularly convinced. And I think that's really interesting because I see a lot of patients with chest pain who have mildly raised troponins, and I send a lot of them into for medical review, and they get a second troponin, and they see the chest pain nurse, etc., etc. And the amount of time I sort of go, they're not in an event, but they've got a trop of 30 or something, a slightly raised trop. The amount of times that actually there turns out to be an event, the next trop's 300.
That's evolving.
But it's just really interesting because I see a lot of that, and I send in a lot of patients who I don't think have had an acute coronary event who turn out to have had an acute coronary event. And it's just like, we talked about it in the ACS podcast, it's difficult to pick up these patients because they present weirdly. They don't present like the textbook says. They don't come in saying, there's an elephant out my chest. Sometimes they do, but a lot of the time they don't. They present in weird ways, like the chap in this case. Certainly in the elderly, certainly diabetics, Afro-Caribbean populations, they present without pain, they present with sweating, with shortness of breath, and it's very difficult to pick them up, and that's why we miss it.
Yeah, and I think, for going back to your question, Sara, I think it's completely dependent. I think left bundle branch block is very, very common, and so, but potentially what the alternate history that you were giving where there's no chest pain might have alluded to something like a crescendo angina, where there's a bit of angina, but it's getting worse, and it's kind of getting worse, and it's getting worse, and that's a preceder to then having a myocardial event of some sort, particularly if it's coming on at rest. What the differentiation to make, I suppose, particularly in general practice, is, does this patient need to go to ED now, or does this patient need an urgent cardiology referral?
Okay,
which is kind of outpatient based, but going into secondary care, and I think that's the delineation. If you don't have pain at the moment, thinking about weighing up the risk versus benefit, and particularly in this individual who didn't want intervention.
Yeah, that was the other thing. Someone who's so scared of medication that he's 70 something, and hasn't ever seen the doctors. I think he had 2 consultations ever. We were now saying, you're going to go to hospital, you're going to have blood tests, and now possibly he's being considered for a triple bypass. So that
which is a serious, it's a serious operation, really, isn't it?
Yeah.
Yes.
Yeah. No, it's not a question. Sorry, it's a statement, isn't it? Yeah. So no, it's good. It's a good case, and I think it just makes us question, actually, doesn't it? And really highlights the abnormal way in which these quite serious patients can present, and the issue in primary care is that a lot of people will come in with a lot of weird and wonderful symptoms, and it's about catching those patients who actually aren't that stable and are presenting with the weird and wonderful. It's a needle in a haystack situation, isn't it? Especially when you have 10-15 minutes each appointment. So you're actually lucky to be in a surgery, I think, where there's access to things like ECGs and stuff, because not every surgery has one.
Yeah, that's a good. I mean, a lot of patients who will present to the GP with chest pain will get an ECG, but would come back this afternoon or come back the next day. Sure. And I find that it's a different world for me.
Yeah.
The Royal College of Emergency Medicine target is if you present to the department with chest pain, you should get an ECG within 15 minutes. And that's obviously the polar opposite that we see in practice from GPs, where they're obviously under a lot of pressure as well. Often elderly patients who've been with what we classify atypical chest pain, getting an ECG, very delayed ECG.
Outpatient ECG the next day.
Yeah. Yes. It's just scary, the amount of stuff that we're potentially missing. Quickly ask you, Sarah, so you're nearly fully qualified F1.
Yeah.
So it's close.
Scary.
Has this case changed how you approach patients?
Yeah, I was going to say, I feel like now I might just ECG episode.
Irrespective of symptoms.
Well, because either way we were
Paronychia, ECG.
Yeah. Either way we were like, well, he doesn't. It's abnormal. I don't think this is chest pain, but I'm going to ECG it. And then when we got the findings, well, we don't have a historic ECG to compare it to. So either way, the lesson for me is he probably should have had an ECG quite a while ago. Like elderly people, should they not? It would be quite useful for people to have an ECG generally in the bank. And someone like that, like me, the GP, no one there. The person who we were persuading to do the ECG, no one was convinced. So I'm just maybe be a bit more aware of the atypical ways that something like ACS can present in.
It's having that really broad net. And actually, it's that excellent clinical reasoning of, I don't think this is going on, but I need to exclude it. I don't think it's having a good I need to exclude it, so I'm going to do an ECG. And that's the best way forward. That's how that's going to lower your risk of missing stuff, is by having a really broad net.
And that's where clinical acumen and guideline/protocol come together. So if you rely totally on clinical acumen, there will be some things that are missed.
Yeah.
If you rely totally on guidelines and no clinical acumen, then some things will be missed as well. And that's where they come together really well.
Yeah.
And I guess that's what comes with experience, doesn't it? That questionable doubt that needs intervention. So Sara, then one take-home message, and we'll do one each.
Do ECGs. That would be my take-home message.
She's stolen my one. So my one is what I just said. So rely on your clinical acumen, but also rely on guidelines and protocol. Meet in the middle.
I think mine will be acute coronary syndrome presents in weird ways. Have a broad net.
Broad nets catch more fish. It's not a saying, but it is now.
It is now. That's going to be our new catchphrase. Brilliant. Well, thanks so much for coming in.
Thank you.
It's great to hear that you're actually doing stuff on placement. Never got that.
It's just good to hear from a student voice, isn't it? Because otherwise it's just me and Matt talking to each other. Sometimes we don't even record.
If there's any students out there that have been inspired, or any non-students who've been inspired and got an interesting case that they think others could learn from, drop us an email. Tweet us. Is there Twitter?
Yeah, the Twitter is tweetable.
Do a Twitter. And we'll book you in. Fun?
Do a Twitter
so
on the line.
much fun.
So much fun.
Yeah, highlight of the year. It's not convincing.
I'll take that.